Welcome back. This is episode 5, and today we're diving into the next chapter. Let's get started. Chapter 5. The birth experience. Please, would someone shut off the lights? A gentle-looking woman asked in German. From the excited whispers and shuffling that followed, apparently everyone else in the Kantonspital in Basel was as anxious as I was for the film to begin. Technically, what followed was something less than perfect. The images inexplicably went in and out of focus, and one had to strain to hear the voices clearly. Somehow, though, none of that mattered. Just by pointing the camera at new mothers and their children as they first set eyes on each other, the director had managed to create a genuinely moving film. Thinking about this movie later, I realized it was not only a superb documentary on birth, but also an accurate depiction of our attitudes toward it. For most of its 45-minute running time, the film dealt with the mothers and their reactions. The camera lingered on their faces as they caressed, stroked, and soothed their new children. Since the subject of the film was childbirth, the babies were bright-eyed and awake, but only brief shots of them appeared. Clearly, they were the supporting cast in this particular drama. The real stars were their mothers. This view is hardly unique to the film, of course. In depicting birth largely from the mother's perspective, the camera was simply reflecting what most of us think of when we think of birth. It is the mother's eyes we see it through. It is her joy that evokes our sympathies. We assume her child feels nothing, that he is an innocent bystander at the celebration. This is simply not true. For his mother, for his father, his birth may represent an unperishable memory, the fulfillment of a lifelong dream. But for the child himself, it is something much more momentous, an event that imprints itself on his personality. How he is born, whether it is painful or easy, smooth or violent, largely determines who he becomes and how he will view the world around him. Whether he is 5, 10, 40, or 70, a part of him always looks out at the world through the eyes of the newly born child he once was. That is why Freud called the pleasure and pain that accompany birth primal emotions. None of us ever entirely escapes their pull. To understand why, try looking at birth through the child's eyes for a moment. By the end of his 9th month in utero, he has become deeply aware of his universe. Its sensations, sounds, and sights are as much a part of him now as his arms and legs. This is not meant mystically. He is, in the most fundamental sense, at one with his world and it with him. He has received messages from his mother and through her from the world. They will momentarily disrupt his tranquility and begin laying the foundations of his emotional life. As I said before, minimal anxiety messages will help the unborn develop his sense of self. Except in rare cases, though, brief disquieting messages of ambivalence or anxiety from an otherwise caring mother will not affect him. Birth, on the other hand, is the first prolonged emotional and physical shock the child undergoes, and he never quite forgets it. He experiences moments of incredible sensual pleasure, moments when every inch of his body is washed by warm maternal fluids and massaged by maternal muscles. These moments, however, alternate with others of great pain and fear. Even in the best of circumstances, birth reverberates through the child's body like a seismic shock of earthquake proportions. One moment he is floating blissfully in a pool of warm amniotic fluid, the next he is suddenly thrust into the birth canal and the beginning of a trying experience that may last many hours. For most of that time, maternal contractions will push and pinch at him. What the full force of a contraction feels like can only be guessed at, though some recent radiological studies show that as each contraction closes in on the child, his arms and legs flail wildly, in what looks very much like a painful reaction. Almost as unnerving is the end point of his birth. When the child finally nears the vaginal opening, his still fragile skull may suddenly be seized by 2 steel forceps, and his 6, 7, or 8-pound body pulled forward at a force equal to 40 pounds of tension on his neck. Or he may find inserted in his scalp a tiny metal electrode lead from a fetal cardiac monitor. Even if he manages to avoid both these hazards, he will likely soon find himself in a cold, noisy, harshly lit room, surrounded by a group of strangers who clutch, probe, and pull at him. Meanwhile, his mind is recording every feeling, gesture, and movement. Nothing escapes his attention now. Even the most minute details leave indelible memory tracks, though the child will rarely be able to recall these memories spontaneously later. Almost none of us can. Birth produces a kind of amnesic effect. There is good reason to believe that it does so because of the oxytocin, the male body's principal hormone for inducing uterine contractions and lactation, secreted by the mother during labor and birth. Recent studies, which will be examined more closely in Chapter 10, show that oxytocin induces amnesia in laboratory animals, so it may be that the presence of this hormone accounts for the fact that so many birth memories slip from our conscious recall. Certainly, we know birth memories exist, and we also know they can be retrieved if properly prodded. Dr. Penfield's studies demonstrated that, but his work dealt with early memories. Dr. David B. Cheek, in contrast, has focused his attention specifically on birth memories. In a remarkable clinical experiment done several years ago, he took 4 young men and women he had delivered during his years as an obstetrician in Chico, California, put them under hypnosis, and asked each to describe how his or her head and shoulders were positioned at birth. Positioning was selected as a measure of the reliability of birth memory because Dr. Cheek knew there was no way his subjects could know the answers beforehand. Information like this rarely finds its way beyond the obstetrician's delivery notes, and the delivery notes of these young men and women had been under lock and key in Dr. Cheek's files for more than 2 decades. They were the test's corroborating proof. In every case, the hypnotized patient told Dr. Cheek the correct answer, as confirmed by what he found in his files later. He was careful not to consult them beforehand for fear of leading the subjects on. Each man and woman accurately described how his or her head had been turned and shoulders angled at birth, and also the way he or she was delivered. What makes Dr. Cheek's work so significant is its larger implications. If a child can remember something as minuscule as how his head was turned at birth, what about more traumatic events? Specifically, what about the memory of being trapped in the birth canal, or being unable to breathe for several seconds, or of being thrust out into the world weeks, even months before term? What happens when these physical hazards are compounded by maternal anxiety, fear, or hostility? The work of Dr. Cheek and other investigators now makes it possible to answer these questions with some precision. It is even possible to plot the various birth risks and their psychological effects on the child in chart form, complete with graphs and bars. From animal studies and clinical investigations, I have formulated 5 major categories of birth-related psychological hazards, which, though still tentative, incorporate the best and most recent available data. At bottom, in the chart's lowest psychological risk category, would be simple, uncomplicated vaginal births. While my own empirical evidence shows that a large majority of people born vaginally are outward-going, optimistic, and trusting, I cannot point to any one study and say, there, that proves what I've said. But the reports that have been done, and they are largely on animals, indicate that an uncomplicated vaginal birth does confer important emotional advantages. In a study done at the National Institute of Neurological Disease and Blindness in the early 1970s, investigators found that vaginally born monkeys, the monkey's reaction to birth is closest to man's, were much more active, responsive to others, and quicker to learn in the 5 days after birth than cesarean-delivered monkeys, whose mothers had been given a local anesthetic to rule out the dazing effect of heavier drugs. How the cesareans would compare with the vaginal group 2, 3, or 5 years later is another matter. Many minor birth-related disabilities disappear with time. However, among my own patients, I have noticed what may be one long-term effect of a cesarean birth, an intense craving for all kinds of physical contact. This is probably because the cesarean delivery deprives him of the sensual moments a vaginally delivered baby has during birth, both the excruciating pain and the extreme pleasure. These sensual feelings are the forerunners of adult sexuality, and the surgically delivered person may never quite overcome their loss. For these reasons, cesarean deliveries would place slightly higher than vaginal births on the risk chart. On top of them, or about a third to a half of the way up the chart, I would place breech births, which occur in about 1 out of every 35 deliveries. While most breech babies go on to lead perfectly normal lives, studies indicate they run a slightly higher risk of developing learning problems later in childhood. Matching the academic progress of 1,698 Indianapolis youngsters, investigators found that the children who failed at least one grade and required academic remedial help were much more likely to have had a breech birth. At about the same level of risk as breech births, I would place minor momentary umbilical cord difficulties, such as a cord pinch or a cord loop, that quickly corrects itself. Neither is life-threatening, but each can disturb the child's breathing for a few terrifying seconds. For that reason, I suspect they leave long-term psychological marks that tend to be quite specific. Each disability, in fact, has its own internal logic. For example, babies who have had cords accidentally caught around their necks at birth tend, as children and adults, to suffer from a higher rate of throat-related problems, such as swallowing difficulties or speech impediments. This was true of a man I treated who had been a severe stutterer since the age of 6. Very early in his therapy, it became clear that his father was a key piece in the puzzle. As a boy, the patient had been criticized about his speech unmercifully by his father, which, of course, only made it worse. As therapy progressed, however, it gradually emerged that this criticism was only one of several important contributing factors. The man also had a history of throat-related problems. In one session, he remembered having a painful series of tonsil infections between the ages of 3 and 5. In another, he recalled being born with an umbilical cord looped around his neck. Because his birth records were not available, I was not able to verify this recollection. But in the weeks following the emergence of his birth memory, another, more meaningful form of corroboration presented itself. The man's stutter gradually began to disappear. On top of cord difficulties, or about half to 3/4 of the way up the chart in the direction of critical problems, would go premature births. These can vary in degree of severity. A few days prematurity will be of little consequence. A few weeks will matter more, and a few months can be both physically and emotionally devastating to the child. On the most minor level, I have noticed that many of my prematurely born patients tend to feel rushed and harried all the time. I suspect the feeling that they will never, ever catch up is a direct result of their prematurity. They began life rushed, and now, many years later, they still feel that way. There are others, like a youngster I'll call Ricky Burke, whose prematurity leaves deeper psychological scars. Ricky's case came to my attention in a roundabout way. One of the local Toronto radio stations asked a therapist at my center, Sandra Collier, to do a special 2-part broadcast on dreams, nightmares, and their significance. Sandra had done quite a bit of work in this area, particularly on the connection between dreams and forgotten birth memories. And she mentioned this toward the end of the first program. It was one of those odd coincidences. A listener hears a strange voice on the radio, and suddenly her life and her family's lives are changed. In this case, the listener was Kathleen Burke, and hearing Sandra discuss how dreams can express unconscious birth memories made her think about her son, Ricky, and his birth. For the past several years, Ricky had been tormented by horrible, frightening nightmares. Night after night, just after falling asleep, he would thrash about cursing, but cursing in a vocabulary far beyond the powers of any 6-year-old. Stranger still was the yelling and screaming that followed. Sometimes he would also talk of an odd light and speak in "What's that about in what?" to his mother sounded like a foreign language. None of the doctors to whom the Burkes had taken Ricky could help. They would either pronounce his condition undiagnosable or prescribe a medication that turned out to be useless. After listening to Sandra's broadcast, however, Mrs. Burke found herself thinking again about the circumstances of her son's birth. She had had a very difficult labor. Ricky was born prematurely, nearly dead. Gradually, as her mind began focusing on that night, other details emerged. Her overtired doctors had cursed. A priest was called in to administer last rites to Ricky. As his mother was remembering all this, suddenly, everything fell into place. Ricky's nightmare grew out of his birth memory. His swear words were those he had heard the doctors using. His language, the priest's Latin. It all made perfect sense, Mrs. Burke said, when she called during Sandra's second broadcast to tell her about Ricky. Lucky may seem an odd word to apply to Ricky Burke, but considering the difficulty of his birth, he was lucky to escape so lightly. A delivery complication like Ricky's belongs in the last quarter of the chart. Problems in this category include life-threatening instances of prematurity, births that were at least 2 months early, for example, cord difficulties that bring the child within an inch of death, placenta previa, which can block his exit from the uterus at birth, and eclampsia, a potentially menacing form of maternal hypertension. The psychological problems often associated with these disorders are equally severe: schizophrenia, psychosis, and violent antisocial and criminal behavior. As a matter of fact, evidence in the scientific literature overwhelmingly favors the view that physiological complications at birth predispose the individual to a wide range of injuries, from psychological damage to organic brain damage. For example, in a study of 33 schizophrenic youngsters, investigators found a 40% rate of birth complications of all types. The rate for their mentally healthy brothers and sisters was, in contrast, only 10%. More dramatic still are the results of an especially good study by Dr. Sarnoff A. Mednick, director of the Psykologisk Institute in Copenhagen. In the early 1960s, Dr. Mednick began following a group of more than 170 youngsters who had been marked as possible candidates for schizophrenia because their mothers had the disease. Dr. Mednick wanted to know how many of the children would ultimately develop it, and more importantly, why. Within a few years, he had an answer to the first part of his question. 20 of the young men and women had, by then, become schizophrenic. Looking for clues as to why they, and not the others, had succumbed, Dr. Mednick found what he thought were some significant similarities in their backgrounds. He noticed that many of the schizophrenics' mothers had been institutionalized earlier for their disease. He also found that early in their school years, many of the 20 had been branded as troublemakers by their teachers. But the one fact that leaped out at him was the similarity in the 20 victims' birth histories. 70% had suffered one or more complications at birth or during their mother's pregnancies. Turning to the records of the children who evidenced no schizophrenia, Dr. Mednick found a different, but, in its own way, just as telling, a figure. Only 15% had had any kind of complications during pregnancy or birth. Equally dramatic are the results of a second study by Dr. Mednick. His subjects this time were men who had committed violent crimes. Again, he found the one common denominator to be birth history. 15 of the 16 most violent criminals had had extraordinarily difficult births. The 16th had an epileptic mother. Many, perhaps even the majority, of these violent and painful births are either entirely preventable, or in cases where they aren't, their effects can be materially reduced. Sometimes this can be accomplished by providing more of the sophisticated technological medical care that modern obstetrics has come to specialize in. Sometimes by providing less of it, and at all times by paying very close attention to the emotional state of the woman about to be wheeled into the delivery room. How the mother feels at the moment of birth has an enormous influence on how she delivers. If she is relaxed, confident, and looking forward to the birth of her child, chances are very good her delivery will be simple and trouble-free. If she is racked with doubts and worries and is in conflict about the prospect of becoming a mother, the risk of complications rises accordingly. We know that not just from the delivery records, but from what are, in a sense, the eyewitness accounts of the soon-to-be-delivered infant. During these hours, the child is, among other things, acutely aware of his mother's feelings, and often his or her memory of those maternal emotions may surface decades later, spontaneously or in therapy. One of the most arresting accounts of this nature came to me from a middle-aged woman I had been seeing for about a year. It surfaced one afternoon toward the end of what had been an emotionally exhausting session for both of us. The woman was talking about something unrelated when suddenly she stopped in mid-sentence and her facial expression changed. Before I had a chance to ask her what was wrong, she began describing how frightened her mother had been during her birth, how she felt that fear had made her mother withdraw into a protective ball. "I knew she wasn't going to help me be born," the woman said, and I was scared because I'd have to do it all by myself. Another patient, a slightly younger woman, delivered by cesarean, had an equally dramatic birth memory. She recalled her mother's dread as the surgeon prepared the incision. I could feel her terror as the knife began cutting across her stomach. One of the problems with these accounts, from a strictly scientific standpoint, is that they are very often difficult to corroborate. Either the patient's mother is unavailable or, for one reason or another, cannot or will not recall the particulars of the birth. However, there is a great deal of hard research to support the notion that such positive emotions as confidence and anticipation, and such negative ones as deep-seated anxiety, can affect the delivery process. A University of Michigan study found that anxious women labored much longer than calm women. More definitive still is another report from the University of Cincinnati. In this one, the researchers did not simply look at anxiety per se, but at different kinds of anxieties and stresses, and the effect each had on labor time and uterine contractions. Overall, 10 psychological factors were tested. The 3 that prolonged labor most and produced the most inefficient contractions were, respectively, attitude toward motherhood, relationship to mother, and habitual anxieties, worries, and fears. In other words, the women who had the easiest deliveries also had the fewest ambivalences about motherhood, the fewest conflicts with their own mothers, and were the least anxious generally. One other reassuring finding from this study is how little effect normal apprehension has on laboring time or uterine contraction. Many studies show that birth complications also occur more frequently in seriously troubled women. In one conducted several years ago at Brown University, the subjects were 50 women, half of whom were rated as troubled before birth by investigators, and half as normal, that is, looking forward to birth. After their deliveries, a group of obstetricians unconnected with the study reviewed each woman's delivery record, and what they reported back to the investigators was staggering. All the troubled women had had at least one complication during delivery, from relatively minor ones, bearing a child with a bruised nose, to major ones, in several cases, prematurity, and in 2 others, stillbirths. The data on the women rated normal was in its own way just as spectacular. Not one had had any complications or problems delivering. Of course, this does not mean that every severe maternal stress will necessarily harm a child. Still, who knows how much physical and emotional pain we, and by we, I mean such health professionals as obstetricians, psychiatrists, midwives, and nurses, could prevent simply by starting to pay as much attention to the pregnant woman's emotional health as we do to her physical health. One other measure that could probably decrease the physical dangers of birth and certainly reduce its psychological hazards is equally simple. All it involves is using drugs, forceps, fetal monitors, cesarean sections, and the other elaborate technology that has gradually come to dominate birth with more restraint and wisdom. In cases where mother or child is in danger, this technology can literally mean the difference between life and death. That is what it was designed for: emergencies. Unfortunately, most obstetricians use the technology at their disposal routinely on women who don't need it. 80% of American women receive at least one drug during delivery. 30% of the infants born vaginally are dragged into the world with forceps, and 15% of all deliveries are done by cesarean section. How much direct physical harm these and modern obstetrics' other high-powered paraphernalia do to mother and child is hard to say. Virtually every authority agrees birth is better and safer without drugs. Do they actually harm the child? Most studies indicate that, yes, in the short run, they do. Infants whose mothers have had general anesthesia during delivery tend initially to be more sluggish and have less motor coordination. These manifestations may persist many years after birth. Cesarean sections pose the same kind of problem. Virtually every authority, again, agrees that birth is better and safer without surgery. Yet that has not stopped the rate of cesareans in the United States from climbing 200% in the last 2 decades. An important impetus for this alarming increase has been the introduction of the fetal cardiac monitor, which provides an ongoing reading of the child's heart rate and breathing during birth. That, say obstetricians, has helped them spot the baby in trouble sooner and do something more quickly to assist him, usually performing a cesarean section. They claim that with that and the fetal monitor, they can have children who a few years ago would have died during birth, but they cannot really prove it with figures. I agree with those who think that the rise in cesareans is needlessly exposing increasingly large numbers of women and their children to the hazards of surgery. Forceps are another dangerously double-edged obstetrical tool. Given the fact that even the slightest slip of the metal tongue or a bit too much pressure can leave the baby's brain permanently damaged, is it wise to use them in nearly a third of all births? A growing number of experts think not, among them Dr. Cheek, who believes it is the laboring woman's anxiety that causes her to tighten her pelvic muscles, which, in turn, leads to the excessive use of forceps. If mothers were better prepared for childbirth, the number of forceps injuries could be drastically reduced. He cites tension and migraine headaches as problems that are often traceable back to forceps deliveries. That these conditions might be related to forceps occurred to Dr. Cheek under unlikely circumstances. He was taking a cruise when one of his fellow passengers was struck by a severe headache. The man had a history of headaches that always hit in the same place, the forehead just above his right eye. The passenger was sure they had been triggered by a bad eye infection he had suffered as a boy, yet he was proved wrong. Under hypnosis, he briefly described how the eye infection occurred, but he quickly drifted back in time to his birth, which from his account had evidently been a harrowing one. He remembered his mother's cries and then felt his head explode with terrible pain. In response to a question, he said his forehead just above the right eye hurt most, but he could also feel something sharp at the back of his neck toward the base of his skull. To Dr. Cheek, this sounded very much like a high forceps delivery, or rather an attempt at one that had misfired. The forceps, and hence the pain, should have been located at the sides of the infant's head, behind the ears. That they were not, and that the forceps tongue causing the most pain was pressing against his forehead seemed to explain the original sources of his headaches. Dr. Cheek might have left that ship with nothing more than a hunch and an interesting story, but for a chance encounter on the dock with his new acquaintance's mother. No doubt the last thing she expected when she arrived to meet her son's ship was to find herself being questioned about his birth. But when Dr. Cheek explained why he wanted to know, she said that his birth had indeed been very difficult. She was in great pain throughout it. For a few moments, he had been dangerously close to death. What saved him, and just barely, she said, was the high forceps delivery her obstetrician had executed in desperation at the last moment. Of course, one story, even one where every small detail has been independently confirmed, does not make a case. Dozens of things from simple tension to brain tumors cause recurring headaches. We do not know how prevalent forceps injuries are because we have done very little research on the long-term consequences, not just of forceps, but of all the other routinely used obstetrical practices and procedures from ultrasound to episiotomies. Obviously, there will be times when these procedures are absolutely essential, but they are used routinely now, and that is clearly uncalled for. As Dr. Leboyer has noted, it would be hard to think of a more frightening introduction to the world than the one obstetrics has, however unwittingly devised for this generation of children. More often than not, babies are delivered under harsh lights in a cold stainless steel room filled with gloved and masked strangers. Once born, they are usually snatched from their frequently dazed and drugged mothers and deposited unceremoniously in a nursery filled with other screaming, frightened children. The amazing thing is not that this system is now being attacked, but that it took so long for parents and doctors to realize how detrimental it was for the newborn and his parents. Everything we have learned in the past decade tells us we could not have devised a worse way of birth if we tried. Yet, many children in the Western world continue to be born in a setting that might be appropriate for a computer, but that is wildly inappropriate for the birth of a human being. One small but relevant example of a practice that continues despite all we have learned is the separation of mother and child immediately after birth. Many obstetricians argue fervently that it is necessary because what mother and child need most after the exhausting ordeal of birth is rest and plenty of it. But all the recent work on parent-infant bonding shows that this is untrue, that what mother and infant require and want most in these minutes and hours is not sleep or food, but to stroke and snuggle and to look at and listen to each other. Hundreds of studies have demonstrated this over the past several years. Let me return for a moment to that movie I mentioned earlier. What I and the rest of the audience at the Cantonspittal found so fascinating was how the director had managed to capture this bonding on film. The mothers and children in it were not drugged or dazed or exhausted. They were old and loving acquaintances who could not wait to set eyes on each other. Bright-eyed and alert, the babies began searching for their mother immediately after birth. None of them could see further than a foot or so. Thus, anything as remote as a mother's face was far beyond their range. But each time a mother spoke, her child turned or tried to turn his head in the direction of her voice. As soon as each baby was laid on its mother's stomach, he would eagerly begin inching his way up, in a kind of swimming motion toward her breast. Perhaps the most startling thing, though, was how little these children cried. Until the nurse arrived to take them away, they were perfectly quiet and content. I think the audience was even more struck by the mother's behavior. All of us were health professionals, doctors, nurses, psychologists, psychoanalysts, familiar with birth. Many of us had performed deliveries. But I do not think any of us had ever seen women slip as effortlessly into the role of motherhood as these women were doing on the screen. You could see it in their actions and gestures. Just the way they hugged and cuddled their babies spoke volumes about motherly love. The director of the movie, a young German woman named Sigrid Anausten, said later that one of the things that impressed her most during the filming was the way the women talked to their babies. Their voices grew softer, their words simpler. Even the verbs they used changed. It was all clearly instinctual, because the moment a doctor or nurse addressed a mother, the adult tone automatically returned to her voice, and her language became more complex. Miss Anausten also said she was surprised at how unconcerned these women were about their child's sex. That is usually the first question a new mother asks. But these new mothers were so thrilled just looking at their babies and touching them that they did not notice or think to ask whether they had had a boy or girl until half an hour, sometimes an hour after birth. It was enough simply that the child was there, safe and well. Another thing that Miss Anausten noticed was how confidently the children were handled. Many of the women were first-time mothers, but none was nervous or reticent about holding her child. Each woman held her child the first time as though it were the 1,000th. We do not know how much the children gained from this gentle birthing experience because they were part of a film and not a clinical study. But the results of several recent studies suggest that it is likely these babies did benefit immensely. These reports examined several different kinds of birth experiences and their influence on a child's subsequent intellectual and emotional growth. What they found is that the children who learn the most quickly and seem happiest had bonded with their mother after birth. In other words, pretty much the same kind of birth the infants in the film enjoyed. Furthermore, we know from clinical studies that the infant's memories of his first primal attachment with his mother continue to affect his sense of emotional security years later. That has been demonstrated in the pioneering bonding work of Drs. Marshall Klaus and John Kennel. Those whom the team refers to as bonding infants grew into much more self-sufficient, outgoing youngster than children who were taken from their mothers immediately after birth. There is another classic series of studies that are among the most original and insightful ever done on mother-infant attachment. The investigators, a husband and wife team from the University of Wisconsin named Harry and Margaret Harlow, wanted to determine what would happen if you took a group of monkey right after birth and put them in a cage with artificial surrogate mother. To find out, the Harlows designed two types of what were, in essence, monkey versions of a scarecrow. One had a wire-framed body, a wooden head, and a nipple protruding from one of its wire breasts, which supplied milk. The second mock mother was identical, except that the Harlows draped a terry cloth towel over her body. The nipple protruded through a hole in the towel. That simple addition, it turned out, made all the difference in the world to the monkeys. The infants caged with the wire mother drank as much milk and gained as much weight as those who had a terry cloth mother. But whenever the monkeys were given free and equal access to a wire and a terry cloth mother, all of them spent their time with the terry cloth version. They clung to her and hugged her as if she were a real mother, something that never happened with the wire mothers. One day, when the Harlows sent a tiny wind-up mechanical toy marching noisily through their common play area, all the frightened little monkeys immediately ran to the terry cloth mother. She had earned all this trust and affection simply because she had been draped with terry cloth. If even baby monkeys have this kind of extraordinary sensitivity to touch and feel, what about the 3-day-old human child? What goes on in his head as he lies in an impersonal, noisy nursery surrounded by strangers? How will the absence of all meaningful human contact during these critical affect him later, affect his feelings toward his mother, his father, and, one day, toward his own wife and children? Can there be any doubt that he would feel better if he stayed with his mother more and by himself less? Chapter 5 is now complete. That's it for today's episode. Stay tuned for the next one. Until then, take care and see you soon. Thank you.